Today we're going to operate on several patients that have contained lumbar herniated discs. We're going to use the Claris instrumentation for percutaneous discectomy. This is a very successful procedure that has been used for many years in my practice over several decades. Patients have excellent results, the risks are minimal, and they're back to work quickly. I hope that you learn to do this procedure and can utilize it yourself in your practice and help many patients. Okay, we're about to demonstrate the Claris Nucleotome used for percutaneous discectomy. The instrument has 3 tubes coming from it, and we're going to attach these tubes to the console. The 3 tubes have a purpose. The first tube is for driving the knife, which is powered by nitrogen, so we're going to hook it up to a nitrogen tube. The second is for aspiration, so that we can suck the nucleus pulposus, or the center core of the disc, out and put it into a catching type trap. And the third tube is for hydrating the disc, through which we pass water into the disc. So I'm going to hand this 3-tube device off to the nurse so she can hook it up to the console. This is the console that you're looking at, the Claris console, and it powers the knife, hydrates the disc, and sucks the disc material out to perform discectomy. Thank you, nurse. So she's hooked the tube up to the nitrogen, the second tube for suction into the suction canister, and the third tube to hydrate the disc from the saline bag. The tip of the nucleotome has an opening, or an area that is pulsating to cut the disc and suck it out. The opening is only on one side, and that side is designated by this raised zone, which tells me where the opening is. So during the procedure, once we're in the disc, we're going to turn the nucleotome in a 360-degree circumference. That will go around the disc center. We're also going to telescope the instrument to go from one side to the other. Before we begin, we're going to prime the tubing. The tubing is going to be filled with 0.9% sodium chloride injection USP, and the purpose is to remove the air. And we have a basin filled up with this sodium chloride, and we put the nucleotome into the fluid, and we step on the pedal, which activates the nitrogen knife. Go ahead. In doing so, we're taking water through the tubing and removing the air. The purpose is to remove the air bubbles. It's sucking the water through, and it's dropping it into a canister. Once we see that the air is removed, then we can stop. This is a patient that has a herniated disc at L5-S1, and it is pertinent, that, of course, that we identify the proper level. So the first thing we would do is look at the x-ray in an AP view, and we count down to make sure we're at the proper level. So this is L1, L2, L3, L4, L5, and this is L5-S1. Skin marker, please. Okay, go into a oblique position. So now we want to identify the entry zone as to how we're going to enter this L5-S1 disc. Picture. Up tilt. Picture. The iliac crest is often going to obscure our vision, and if we look at this iliac crest, it's doing just that. So we'd like to level out the plateau or the end plate, and we can do this by further up tilting the X-ray machine. So give me some up tilt, and that's perfect. So now we're beginning to open the zone over here, and we're going to try to move this facet joint over to create an opening. So down oblique, please. And we create this opening over here, which is going to be our entrance zone. Some more down oblique. Picture. And we can now see this opening in a fairly decent manner. So we've identified this, and we're going to now anesthetize this area with xylocaine. I use 1.5 inch 25 gauge or 22 gauge needle. I then again give additional xylocaine by putting a 22 gauge 5-inch long spinal needle into the zone. Under fluoroscopic guidance, we'll go straight down to where we want to be. And can I have some xylocaine, please? I'm using as much as 6 to 8 cc's of xylocaine, just infiltrating the area so that when we begin, the patient will not feel it. And now I'm going to use a knife, number 11 blade, just make an entrance zone. You may have the guide wire. This guide wire has a handle on it which allows us to manipulate or move the wire. The wire has two ends, a blunt end and a sharp end, which is a trocar type end. We go through the opening of the skin that's been made, and under fluoroscopic control, we're going to try to enter the disc through this very small zone. We're going to guide this straight down. Just keep on looking under fluoro to make sure that you're in the proper zone, moving the guide wire so that we're going to go straight down. And once we feel ourselves going through into the disc, go lateral, please. We look at a straight lateral picture, and we can see that we're just about in the disc, and we're going to pass it in. Picture. Okay, this shows that we're exactly in the center of the disc where we're supposed to be. Now, to confirm position in the anterior posterior view, we will move the X-ray tube into the AP view quickly. Picture. And oblique it to me a bit. Picture. And this looks like a perfect position, almost midline in AP and in lateral view. Go back to the lateral view. Save this picture, please. We remove the handle. And can I have the blunt trocar? This is the instrument we're using. It's basically, I believe, around a number 15. This is a skin stop, which is movable. Inside of this is a blunt trocar. So we're going to pass this instrument down to the annular rim. Once that's done, we'll remove the blunt trocar, put an identical instrument in, which will have a serrated edge and allow us to enter the annulus itself. We pass this right over the guide wire, and we have to go through the iliolumbar fascia, which should be anesthetized with the local xylocaine. Picture, please. One must be careful not to push the guide wire through the anterior annulus, so every few inches we check it again. Okay, can I have the serrated edge now? So we put the serrated edged instrument directly over the guide wire, removing the blunt. And now we're going to core into the annulus to enter into the disc picture. I'm going to extract the guide wire back further, and now set the skin guide so that we don't go in any further. We're going to remove both the guide wire and the serrated edge trocar at one time. We've already prepped the nucleotome, now picture, and this is perfect. So what I'm going to do now is, under a fluoroscopy, move this in and out. So I'm going in and out of the disc. I fixated the instrument by putting the skin tag down. I'm holding the trocar in my hand to prevent it from going in and out, holding with my left hand, using my right hand to telescope the instrument. We continue to see disc material coming out, and this is a very nice yield of disc. Of course, we're taking out the nucleus pulposus, and we continue to see large pieces of nucleus pulposus being removed. In order to get this disc material out completely, we can lean the instrument down this way, up this way. So if we bring it down this way and insert, we're going to go more to the midline and retrieve more disc material. If we turn the knife, the nucleotome, and push it down cephalad, it's going to move the opening caudal. And throughout the procedure, we're moving this 360 degrees, pushing in, pushing out. Always watching the fluoroscope, making sure we're not going through the center portion of the disc, out to the anterior aspect. Now, the length of time that we use the knife or continue this procedure is at the discretion of the surgeon, and it's continued until the surgeon feels that the disc has been fully evacuated, until we feel that the disc is emptied. Usually the most time this take is 20 minutes, but usually in a general sense this is done at least 7 minutes. So at this time I think we'll stop. The nucleotome is removed. Holding the trocar, we'll inject a cc of depomedrol and a cc of Marcaine 0.25% plain. I do this on a spinal needle right through the opening, and I put it in under a little pressure. And the Marcaine will be next. Some surgeons will mix the two together, and that's perfectly fine. This is Marcaine 0.25%. At the end of the procedure, the instrument is withdrawn, and that's the end of the procedure. We're left with a very small opening, virtually non-existent, which is covered with steri strip, and that's it.